Often the question that is asked is, when a patient relapses, should he be given a 2-drug regimen, or do we need to use triplet regimens that certainly have become established in the frontline setting, especially for transplant eligible patients? I think that the data from multiple clinical trials which we have discussed shows that the use of a triplet leads to better disease control, both in terms of depth of response and durability. So I think that I, whenever possible, would like to use a triplet for patients, and this patient I think could tolerate a triplet of ixazomib with lenalidomide and dexamethasone, or if he had been totally asymptomatic, even elotuzumab with lenalidomide and dexamethasone. However, there are some patients, especially over the age of 80, who are still not candidates, I think, for 3-drug therapy, and for them often we move from serial 2-drug regimen at beginning to a 2-drug regimen at time of relapse. For an octogenarian, it is not uncommon for me to start a patient on lenalidomide and dexamethasone, and then when he progresses, the patient may go to just a 2-drug regimen of ixazomib with dexamethasone. Though not FDA approved, it is a valid choice of therapy. And then they often want still an oral therapy beyond that, and then going to pomalidomide and dexamethasone at that point is often what I end up doing. Also, in this situation, the use of single agent daratumumab is an option when patients are older and you want to not subject them to the toxicity of treatments. That is a regimen that has single agent activity. So I think you have to look at the patient to decide whether it should be a 3-drug regimen or a 2-drug regimen, but certainly, if possible, giving a 3-drug regimen is best. The Tourmaline-1 study, which led to the FDA approval of ixazomib with lenalidomide and dexamethasone, was a large phase 3 study that compared the 3-drug regimen to a 2-drug comparator of lenalidomide and dexamethasone. This study showed that the progression-free survival, which was the primary endpoint of the study, was superior with the use of the 3-drug regimen. Also, what was shown was that in subset analysis, the study showed benefit even for patients with high-risk disease, patients who had 17p deletion, who are considered the highest risk subset, and also those that had other high-risk features, including translocation 414, 1q plus. All of those patients seemed to benefit by the use of the 3-drug regimen compared to the 2-drug regimen. So I think that for this patient who has high-risk chromosomal features, ixazomib with lenalidomide and dexamethasone would be a very appropriate treatment option. It is often perceived that for high-risk chromosomal features, that the only things that are going to work are really the intravenously administered drugs, but that I think is not what is supported by data. The Tourmaline-1 study showed that even in the high-risk subgroup, an all-oral regimen was appropriate. The use of ixazomib, lenalidomide, and dexamethasone for the high-risk population is supported by subset analysis of the Tourmaline-1 study. What we saw in a publication in Blood just recently is that those patients who had high-risk chromosomal features, including 17p deletion, 414 translocation, 1q plus, actually seem to have a greater benefit with the 3-drug regimen compared to the lenalidomide and dexamethasone control, compared to the whole group of patients in the trial. So though everybody benefited, it seemed that those that had high-risk features had the maximum benefit.